Excited about our next speaker. He's got a product that many of you are aware of. Michael ONeil began working in healthcare as a counseling psychologist and moved into healthcare services in 2002, where he held a profit and loss responsibility for the Medicare Advantage book of business as a general manager for Healthways. Following Healthways, Michael led strategy and development as a senior vice president for HealthSpring, a $6 million publicly traded company, which was later acquired by Cigna. Excited today for Michael to continue to talk to us about the great things that are going on with Healthcare Blue Book and how your work can be made better and made better known to consumers. Join me in welcoming Michael.
All right, is that working? Good afternoon. Well, thanks for the intro. I'm not sure who writes that stuff, but I'll take it. This is my favorite sort of form, self-labeled free market enthusiasts, folks who aren't waiting for anyone else to do it for them. There's really only 2 occasions I can think of where I'll put on a suit on a Saturday, and this is one of them, so delighted to be here with you guys. So we're going to talk about where things are today, where we think they're going tomorrow, and where they're going in what used to seem like an Arthur C. Clarke term of 2020, which is only 4.5 years away from now. And we're going to go through pieces that we've talked about throughout the 2 days, but with a different spin, perhaps. What is the core issue? And Adam and others and Jay hit a lot of the employer-employee misalignment. We're going to talk further about the provider and the payer misalignment. What's driving that? What's the opportunity to drive it in a different direction? And where we think things are going next. So before we go further, let's frame what's underneath the issue and the opportunity for the folks in this room. Cost and quality vary by huge amounts, 3 to 10x for the same service, right? And we're going to look at data nationally and in this market as well. But that's just data, and as we all know, we've got a job in terms of educating the broader populace about why this matters. So you have to translate data into something real. Some of you heard this before. If you have, don't spoil the punchline. But the reason the Blue Book was started, our founder, Dr. Jeff Rice, who was here last year, he has a son, now a teenager, who needed a 1-hour outpatient procedure on his foot. And we're based in Nashville, and he was flying to another state to try to find the best pediatric orthopedic surgeon he could. He and his wife and his son traveled, met with the surgeon to review the case, and asked the doc, that sounds great, where are you going to do the case? 1-hour outpatient procedure on the foot. So I can typically do it at this hospital over here. So, and this is, bear in mind, 6-7 years ago. So Dr. Rice calls the hospital and says, hey, can you tell me how much this is going to cost? Anyone want to hazard a guess as to what they said? Right, we don't know, and with an addendum to that. Why are you asking? He said, well, I'm paying the first $3,000 of this, so if you want to get paid, I'd like to know. Okay, we'll get back to you. Literally a day goes by, they call back and say, we think it'll be roughly $35,000. So that sounds kind of high. Is that take into account the network discount with Aetna in this case? So, oh, no, Dr. Rice, we'll get back to you on that. Another day goes by, call back. Good news, it's going to be somewhere between $15,000 and $25,000. Said, for a 1-hour procedure on the foot. All right, thanks very much. So he goes back to the surgeon and says, look, do you do this anywhere else? He said, oh, sure. You know, I thought you wanted Wednesday, but Tuesday, Thursday, I do it downstairs in the OR suite in this office building. Great staff, great crew, it's all we do. You know, drive-up parking, more convenient. Happy to do it there. So Dr. Rice calls down to the surgery center. Same surgeon, same procedure. 1 phone call, 1 immediate answer. What do you think the facility said it was going to cost to do it downstairs in that building? What was the answer? You guys are too good. $1,500, right? So from $35,000 to somewhere between $15,000 and $25,000, you've heard this story before probably, to $1,500, right? And the point is not that that happened to Jeff, but that happens to your colleagues, your employees, your family members all the time when they're out there bouncing around the delivery system without champions, right? Like Kempton, like HealthSmart, like the Oklahoma Surgery Center, and many others in this room. So think about that as the frame for why we're actually in this room together. There are lots of easier ways to make money than in healthcare, like consider the status quo healthcare, really easy way to make money. What we're doing is hard, but it's important. All right, so taking a step back, looking at the macro picture, this is the key challenge in healthcare that you're all aware of. We spend way more than other countries and get less for it, right? Pushing 18% of GDP, and we spend 4x what some countries do with the same level of outcomes and life expectancy. Now, this is with credit to Dr. McCary. I steal freely when I see good stuff. So, anyone want to hazard a guess what the third cause of death is in this country annually? Please.
Sticker shock.
Good answer, but no. Anyone, what's the third leading cause of death? I'll give you a hint. It's not heart disease. It's not cancer. Hospitals, generally correct. It's healthcare, period, right? Most of this is occurring inside of hospitals. But these are annual figures from the CDC. Obviously, this one here is more of a conservative estimate than a recorded, because they don't put cause of death, healthcare, right, on the death certificate. But they should, right? So it's ahead of chronic respiratory disease. It's ahead of accidents and stroke. Think about that for a minute. This is an industry whose job it is to keep you alive and healthy, and they are the third leading cause of death, right? So however you look at it, value is not coursing through the system despite all that we're paying. I mean, you saw the figures, 18% of GDP. That's not a phantom number. That's coming out of our pockets in one form or another through taxes or salaries, teacher salaries, et cetera. But this is what's stunning. Even with that kind of performance, this is what's happening to prices in healthcare. So notice when this started, right? There's two lines here, the CPI and then the medical price index. Somewhere in there when Medicare and Medicaid started, but more importantly, when PPO world took hold. Look what happens to the red line. Takes off unchecked, right? Looks a bit like a pricing bubble. And we know what happens to pricing bubbles, right? Whether it's the market, housing market, commodities, eventually they pop. That's our job. Our job in this room is to pop that bubble. And people don't realize when you're in a bubble that things can change. Buyers can move away from sellers when they're in a distorted market like this. And when you look in this market in particular, so this is data that we do all across the country with partners like HealthSmart and Jake Hampton and many others to show based on allowed amounts. So back to what Adam was talking about this morning, the true price, right? Not the discount off of bill charges or some funny sticker price, but the real price. What's the variance in cost inside a market for the same procedure? Look at some of those. Right? The surgery center, I think, is probably the $2,700 price for the knee arthroscopy compared to $18,000 for some hospital across the street. And this is not atypical. We see this pretty much everywhere we go in the country. And I believe someone yesterday was speaking about translating this to a consumer product like gas. Think about that for a minute. You're looking at over 700% variation for the same product. Same product. You would never spend $16 a gallon for gas. But you're doing it, your employees are doing it, state employees are doing it with your money. This is what's happening in healthcare when it's managed by the status quo of payers and providers. Yes?
Is this just a facility or is it a bundle?
That's all in. The question was, is that just facility? No, that's the, if a facility, physician, and anesthesia is included, such as in the knee arthroscopy, that's all in. So why is this happening? Well, you look at both sides of the teeter-totter, the payer and the provider. The status quo hospitals, they've done a really good job at using capital to consolidate their position, right? They're buying up rural hospitals, they're buying up chains, and by the way, we're based in Nashville, which is, epicenter for for-profit hospital systems, and then it's a feeding frenzy. Then they buy up docs, and you've seen that pendulum go back and forth, buying and selling physician practices, but because the referral channel, steerage, feeder, whatever you want to call it, is so powerful now, they're willing to pay way up. And we're seeing a sustained trend of physicians moving into the big house. They do all this to drive a consolidated pricing front and leverage with payers. Because remember, and I'm talking about the BUCA, I'm talking about the national carriers. If you think about who a carrier's customer is, who's their number one customer? Anyone? It's the network. The number one customer of most carriers is actually the network. How do we keep the network happy? How do we keep it distinct and use it as an advantage to sell against our competitors? The number 2 customer is somewhere between the broker and the employer, but the patient's not even in it because the patient's not really paying the bill. So the carriers have been less than aggressive in preventing this consolidation. And I'll show you why in a minute. It actually behooves them to some degree to allow this to continue. The strategy for driving predictable revenue growth for hospitals has worked. Just look at the publicly traded companies. But the bulk of where that spending growth, that total spending growth is coming from, is not from increased utilization, is not from more invasive or complex procedures or patients. It's from price increase from the same procedure set. Over 2/3 of the total spending growth is from price increases without any upside in terms of value or quality or outcomes. Which is maybe not a surprise then when you look at mission statements from hospitals. So we just did a survey and pulled 100 different hospitals' mission statements randomly and found that 85% of them never utter the words value or affordability. They talk a lot about innovation and scientific research and education and community, this and that and the other, but they're not concerned about affordability or value. We in this room are concerned about both of those. But you're not going to get the status quo to jump on that bandwagon until they have to. They'll do lots of other things first, and we'll look at some of those. What is a priority is brand building. All right, so at last count, how many top 100 hospitals were there? It's not a trick question. Anyone got a guess? Somewhere between 700 and 1,000 top 100 hospitals in the country, right? Everyone's got a list, right? So the billboard effect, I mean, you see it driving down here. We certainly see it in Nashville. You got 2 things. Number 1 in mosquito-borne diseases and a 5-minute ER wait time. That's what they're advertising, right? Give me that niche where I can say I'm number 1, and I'll advertise a quick entrance into one of the least cost-effective locations in healthcare, the ER. And when you look at their own industry language around their strategic wheel, what they're focused on, you'll recognize a lot of these. Revenue cycle management, ACOs, clinical integration, patient-centered medical home. Nowhere in there does it say value. Nowhere in there does it talk about the consumer. But this is the explicit strategy of many of the leading hospitals as well as the advisors to those hospitals. So when you hear hospitals talk about, we're going to solve your problem with an ACO, what do you do when someone says, I'm here from the government and I'm here to help? Right? When the status quo says, we're here to help you change X, but the status quo is financially advantaged by the status quo, they're not going to help you change. So this whole volume for value thing behind ACOs, ask yourself if the provider is actually changing anything about the delivery system. Are they changing the location of care? Are they fundamentally redesigning the process of care? Or is this just a contracting strategy? So the way it goes that I've seen is the hospital will say, this is what I was making last year. Here's my revenue. You can paper it however you want, but I need to have that plus 5% next year. You can call it value, but I can't have less than that next year. So the value to volume for the status quo providers is their value. They want to make sure their value remains constant. Compare that to a handful, and I literally mean like on one hand, the number of hospitals that are actually trying, and providers in general, that are trying to drive to earn value, to earn volume by delivering value. That's what the folks in this room are doing, right? That's what the surgery centers are doing and other free market medical professionals and leaders are doing, is winning market share by delivering better value. But that's the difference between status quo and free market. You guys doing okay so far? All right. So that's one side of the teeter-totter. The other side of the teeter-totter is the payer, status quo payer, right? Distinct, different species from the true facilitators of value in Kempton and HealthSmart and others in this room. This is why, whether this was an unintended or an intended consequence, I don't know, but this is why status quo payers and carriers are not going to help you solve this problem. Once you mandate that the maximum profit someone can make is 15% of the total medical spend or 20% of the total medical spend, you've got one way to increase your profit. One way. Grow the pie. Increase total medical spend. Payers are not incented. In fact, it works against their shareholder commitments to drive down the total cost of care, because that drives down their margin by definition. Right? Simple, basic premise, but you have to wonder then why you're looking to them to solve your cost problem. So back to that point of when the government shows up and says, we're here to help, reach for your wallet and run. When a carrier shows up and says, we've got a way to help you with your cost problem, same issue. So look at narrow networks. And I don't mean true high-value networks like a lot of the folks in this room are involved in here, but narrow networks as defined by a carrier. So we peel them apart, and that's what we do. We look at them. So we'll take an example here of one in the Southwest. It's a carrier-led system, carrier-designed network organized around a single major hospital system that has about 16 of the 40-ish hospital facilities in the market. So when you slice it finely, as we do, and you look at a specific clinical category, like cardiac care, and what you're looking at here, each one of these vertical bars is a hospital in the region. We look at the MedPAR data, right, which looks at all hospitals across the country, risk adjusted, volume adjusted, and look at true outcomes based upon mortality, morbidity, complications, readmissions, et cetera. And what you see is the green hospitals, right, they're in the top quartile nationally against all hospitals for cardiac care. The red are in the bottom quartile and the yellow somewhere in between. So each one of those black arrows represents a hospital that's in that narrow network. So if you were the employer in this market and said, I love this narrow network idea, you're going to get me a 10% discount, I'm going to do it, this is what you're actually buying into. That narrow network's going to prevent you from going to 2 of the 3 best quality facilities in the region. It's going to incent you to going to the worst quality facility in the region. But it gets worse. When you look at the cost picture of it too, as Tom was mentioning, oftentimes cost and quality are inversely correlated. And it makes sense, right? In healthcare, if you've got rework and readmissions and all kinds of other issues going on and your most profitable patients are the ones that you make mistakes on, you're not going to be that cost effective. So this is real data. Looking at one of the narrow network hospitals, they're in the bottom tier, in this case for hip replacement, and yet they're twice as much on an allowed amount basis, twice as much compared to one of the best hospitals in the region. Similar story for knee replacement. And this is what's behind the narrow network argument. We've talked about the complete BS between discount rates and real cash. And we've beat up on Nordstrom's, so I'll continue with that theme. So I've got a 13-year-old daughter, and God help me, but she will come home and have a new pair of shoes, and the first thing out of her mouth is, you won't believe how much money I saved on these shoes. You won't believe it, Dad. Really? Tell me how much money you saved on these shoes. They were 50% off. And where'd you buy them? Nordstrom's. And I have to go on to Zappos and say, you could have the same shoes for 0% off, but half the cost. But for some reason in healthcare, that goes out the window and people focus on a discount rate. So don't buy your shoes at Nordstrom's or Neiman's or someplace else when they're available on Zappos. But here's the bigger issue. If you look at what the carriers have done, say for a regular status hospital versus narrow network, they do get a greater discount rate, an additional 10%. But compare that for the same procedure at a non-hospital owned independent center, right? From $3,400 to just over $1,000, right? So it is 3x the price to go inside the narrow network compared to going to an independent center. But that's not what the consultant or broker talks about. They talk about the discount rate. The real question you should be asking the carrier is, tell me what kind of discount you're going to get on that facility to have it equal the allowed amount of the independent facility. It's 70%. You're not going to see carriers getting 70% discounts from most hospitals that are legitimate. So the opportunity, today, tomorrow, and out 4.5 years to 2020. Right now, you've got roughly 1/3 of the total medical spend that is amenable to consumerism, where someone can really shop for it in advance. It's not overly complex, and it's not trauma or emergent. At least pushing $1 trillion in total market opportunity. A good 80% of that, in some markets it's higher, in not many markets is it lower, a good 80% of that are going to the high cost, low value, or in our world, the red providers. Because they are the default center of gravity in the delivery system. They've got the referral patterns, they've got the billboards, they've got the brand, and they don't have enough folks like the folks in this room driving in a different direction. What we've seen, and we'll show you some data, is that we work with different carrier partners, different TPA partners, and employers in a market. We can begin to flip that around. We can increase the amount of care that's going to the higher value independent providers. And even a small 2, 3, 4, 5, 10% difference makes a significant impact on the employers in that community. This is where we need to be focused. Not just incremental, but there's no reason in a legitimate free market why the buying won't flip on its head. When you're using your own dollars, you would never spend in the red zone when you could spend in the green zone. But how do you get there? So this is one of my favorite frames of what's going on in healthcare and consumerism. You think about it, right? We've been hearing about consumerism for a good 15 years, that finally the consumer has skin in the game and they're going to act like a consumer. But it hasn't happened. And the market can and has remained irrational a lot longer than a lot of good companies have remained solvent, right? There's plenty of logical, rational entrepreneurs and companies that died on the vine because the market wasn't ready for them. And that's where a lot of us have been, right? Is feeling like you're pushing a rock up a hill again and again and again, and it rolls back down on you. And to this point, you've only got about somewhere around a third, maybe a little less, of folks who actually have a high deductible plan sufficient to push them to move and act like a consumer. So the question really is, where is the tipping point? Where are you no longer working against the stream, but it's flowing with you? No one has an exact answer, but I think we're talking about something in the range of when the majority, even by a couple points, the majority of folks actually have an out-of-pocket design or first dollar exposure where they have to act and think like a consumer, all of a sudden the conversation changes. And one of the consequences of reform, with all of its warts, is that if you look at what's happening on the exchanges, the only affordable plans out there are high deductible. So regardless of where regulation goes, a couple things are constant. We're all spending more for healthcare, and we're all going to be spending more for healthcare proportionately directly. So whether you're an employee covered with employer coverage or on the exchange, you're going to have more out-of-pocket exposure, which for the folks in this room is a good thing. That's the beginning of some rational buying behavior. So is this time different? You know, Tom was saying this is probably the most exciting time in healthcare. I'm a relative newbie. I've been in it about 15 years, but it does feel like the forces are bigger and faster, right? So think about where high deductible health plans were back in the early 2000s. Now, every employer just about offers one at least. Some have gone to full replacement. And look what, thankfully, has happened to plan design. PPO designs are down, HMO designs are down. CDHP is way up. The other factors driving this is what's happened to the employers. This is not new news to you, but the growth over the last 10 years in employer contributions comes right out of their earnings. They can't afford to wait for non-effective PowerPoint solutions from the status quo. They're doing one thing they know that works, pushing more of the cost onto the employees. But the employees' pay has not begun to keep up with what their contribution exposure has been, right? They're up almost 200% in terms of what the average employee is paying for their health care. But their pay is up a quarter of that. Are you all familiar with the reference-based pricing results that came out of CalPERS in California, I'm guessing? So CalPERS it's the public employee retirement, but it's one of the largest employers or payers for healthcare in California. And they started a program, oh gosh, back in 08, 09, or 10, somewhere in there, to do reference-based pricing for hips and knees. So in other words, they would pick a price, I think it was somewhere around $40,000, that was the reference price. And they weren't going to pay more than that. So if you wanted to go to some academic medical center and pay $130,000 for your hip, that's great. CalPERS is only going to pay $40,000. And they got real movement, and they generated real savings. And yeah, they upset a lot of people in the process. But the most fascinating thing to me is that 2/3 of the savings came not because they were bouncing back payments to employees, but because once providers realized, I'm talking hospital systems, academic medical centers in California, once they realized that the largest payer was only going to pay X, look at the difference. I don't know if I have a laser on this or not. Yeah, look at the difference pre-implementation. All of these folks in here and especially these outliers up here versus post-implementation. They voluntarily lowered their rates to the reference-based price or as close as they could get to it, because they knew if they were out of that, they were out of the market. So over a year, they shifted the cost of care dramatically just by saying the largest employer isn't going to do this anymore. We've seen something similar in our experience. We work with a regional health plan in Michigan that's owned by a health system, which, if you think about it, is kind of a tough place for a transparency company to show up. And so we were getting down to the final stages of implementation. This is going back a couple of years. And we were kind of waiting for that other shoe to drop, for the hospital ownership to come in and say, we don't like this. And that's exactly what happened. At the 11th hour, they wanted to see the transparency solution, and they saw that all of their hospital-owned facilities were red, high cost, for all these outpatient procedures. They said, time out, we're not doing this. And the health plan said, well, the cat's out of the bag. The employers have asked for it, and we're launching it. So we thought we were done. Within a day, they came back around and said, tell us where we have to set our prices to be green. And before the tool even went live in the market, all of those hospitals shifted their pricing down to the green zone, at least for outpatient care initially, for imaging, and then for some other procedures. So in some ways, the threat of real transparency coupled with real buying behavior by large employers is enough to move pricing behavior in providers in ways that have been too disconnected from large government payers. This was kind of interesting. This was just 2 days ago. Swedish health system, a large, fairly dominant hospital system in the Northwest, they cut their own outpatient prices. Now, they were ridiculously high to begin with. $6,000 for an MRI is egregious, but they're closer to where the market is. They did this for a lot of reasons. Employers are starting to bang the drum out there. We've been out there with a pretty good presence for a while. We like to think that we're part of this, but you are seeing some of the more, whether it's self-preservation or what, forward-thinking hospitals saying, you know what, this is going to happen. How do we get in front of it as opposed to having it done to us? And that's where we come in. So our job as a company with our partners is simple. Stay independent and level the playing field so the good guys can win. That's it. And the good guys are the folks in this room, right? It's the folks paying the bill, the real bill, the employers, the employees, and it's the folks providing real value, the independent providers. And it's the facilitators that aren't just middlemen who are actually enabling what people can't do on their own, the Health Smarts and the Kemptons of the world. So when we do our work, this is where we start. And this is why we're so excited about what's going on here and what's extending in other parts of the country. This is data from one of our self-insured employers. Each one of these lines is a claim for a colonoscopy, right? These are all in-network claims, all based on the allowed amount. So you can see some folks paid over $3,500, some folks paid $1,000. This is in one market in the 12-month period before they began using the Blue Book. And by the way, this employer had a full replacement high deductible plan in place when we took the snapshot, yet they still had 300% variance because employees didn't really understand. Now, the good news for us in this situation is if you look at it a little more closely, you realize that there's at least two components to each encounter in this case. There's the green, which is what the physician was paid, and blue, which is the facility. What do you notice? The physician's not the problem. Where they refer is the problem, but the physician cost alone is not the driver. And every other tool out there, every other approach out there says start by looking up your doctor. And people will do that. And they say, you know what? They're all pretty close. I'll go to the one that's closest to me or whose picture I like the best on the website. And they'll never ask the rest of the question, which is, what should this whole thing cost? And where are you going to send me? And that's the key. Yes, you want to be thoughtful about physicians based upon where they refer, but you're not going to turn the tide in healthcare costs by trying to beat up a doc for their office visit or for their professional side of things in most cases. It's the facility side that is killing us. Literally. And so when we run through this with employers, they say, well, why is that? Why does it cost 2 to 3 times as much if I go to the hospital versus going to an independent surgery center? Well, this is why. So you can't see it up here, but I blocked out some of the names to protect the innocent or guilty, depending on your point of view. But this is for a gallbladder removal. And what you're looking at is it's about $12,000 in an allowed amount, so actual dollars, at a hospital, compared to about $6,000 at an ambulatory surgery center. And the reason behind that is very consistent. In the independent surgery center, you've got 3 line items: anesthesia, the physician fee, and the facility fee. That's it. In the hospital world, you've got everything, including the kitchen sink. And you've got some kind of funky stuff going on in there. So, pregnancy test. Well, you know, if anesthesia, not unheard of to do a pregnancy test. Challenge was this was a male patient. Yeah, he was not pregnant. He was not pregnant, as it turns out. It's good we know that now, isn't it? So that's the cost side of the equation. Looking at the quality side of the equation. It took us a while to find a quality source and process that we felt was valid, right? Because you've seen the 700 to 1,000 top 100 hospitals that are all using quality measures, and obviously can't all be true. So what we realized is when you slice the data by clinical category, you find what you would expect. Most hospitals do most services, but most hospitals are not good at everything. And you see wide variance, right? So this is one such example. And this is based, again, on MedPAR data, so the largest data set that all hospitals have to report into, that you can then risk and volume adjust. So Cleveland Clinic, known as one of the best in the country for cardiac care, and rightly so. They are one of the best in the country for cardiac care, but that's their brand, and that's what they're known for. However, they're one of the worst in the country for joint replacement. One of the worst, but no one knows that, no one talks about it. You think Cleveland Clinic must be good at everything. That's the problem with narrow networks built around a major hospital brand. They're not good at everything, and they're also not cost effective at everything. So what do you do with that information? What do you do with cost and quality information once you tease it apart? How do you begin to package it in a way that gives an employee, a consumer, a fighting chance? What we know about what works is you've got to make it simpler than you think you need to. So we take all that data, both on the cost and quality side, and translate it into a very simple green, yellow, red signaling device with an indicated fair price. So back to that discussion with Adam Russo about what do people care about. If you use the wrong anchor point, if you focus them just on their out-of-pocket, you've lost the game before you start. The concept of fair, though, is a little different because no one wants to be taken advantage of. So we use an anchor point different from out-of-pocket. We say, what is the fair price for a procedure in a market? And then rank all the providers, green, yellow, or red, relative to that fair price. And keep it to no more than 3 steps, right? What do you need? What should it cost? Where can I go to get it? Start there before you get into all the intricacies and drill downs and side-by-side comparisons. You can do all that, but level set the consumer first. And as Adam was correctly pointing out, you gotta have a real incentive. Out-of-pocket's great, but sometimes folks are through their out-of-pocket or it's a preventative service. We use a program called Go Green to Get Green, where you pay the employee, the consumer, when they go to a green provider, period. Right? Because of our partnerships with Kempton and HealthSmart and others, we're able to track the claims feed to see where the employees are going. And when they go to a green provider, we note that and we cut them a check. That's it. And it's not a big amount, right? A couple $100 in some cases. But the sentinel impact when an employee walks into the break room and says, I just saved $2,000 on an MRI and I got $100 in the mail, that's what people remember, right? I mean, think about your own experience. Do you remember anything that happens at open enrollment? Do your employees remember anything that happens during open enrollment? No. But when I've done open enrollments, the one thing people come up and ask me about afterwards, what do you think it is? So the one thing people come up and ask about is, how do I get my check? People pay attention to simple things that show up in the mail with their name on it and some numbers after it. And it's a rare event in healthcare to get paid for something, so it stands out. What else matters to consumers? Well, clearly, real quality. So taking all that complicated MedPAR data and translating it into a simple green, yellow, and red, just as for cost on the quality side. Access. So for green providers that offer the best value in a market, creating direct scheduling requests so that whether it's the patient, the physician, case manager, whatever, you can directly request access to the facility. Try to get all of the barriers out of the way for people who would otherwise get referred to a high-cost center by some other physician that maybe has no clue what the financial side effects are of the care they're prescribing. So as we work with providers, like the providers in this room, our goal is to help connect them with the aggregators of value-conscious buyers, employers and employees. That's what Jay and Tom do at Kempton and HealthSmart. And then highlight the value of those providers that actually understand the financial side effects of their care. Value certified provider is our initial stab at how we're sort of capturing and highlighting these providers who, in essence, the certification is a pledge that I am always going to consider the financial side effects of care. Not that we're going to try to be cheap, but if they can have the same procedure, the same image, the same test, et cetera, for $500 instead of $5,000, that's my job, because that's every bit as real and damaging to a patient as a clinical side effect. So the way we put those pieces together on our site, you've already seen the basics of it, but highlight the good work the providers are doing, the value they're bringing, the value certified provider component that says, I'm going to understand and manage financial side effects for my patients just as actively as I do clinical side effects. Simple direct scheduling request, and then support the employers. What's good for them is good for the employee, is good for the provider. Added incentives to get folks to the highest value location of care. The other thing that I can't overstate is a lot of us in this room are not going to see the full effect of the effort that we're putting our shoulders against, but the next generation is going to demand it. I'm seeing this already in the kids that we hire at Blue Book. So whatever you're doing, it's got to be mobile, right? They're living on a world of small screens, and they have an expectation that thankfully is much more like a free market than not. All right, so looking out again, speaking of the next generation of what the world may look like towards 2020 in healthcare, if you remember where high deductible health plans were in the early 2000s, 2-3% adoption, people thought it was crazy. I remember literally the conversations with the folks from Definity Health when it was a completely novel concept, and brokers, consultants, and the large employers were saying, no, that's way too radical for us. And now it's a norm. It took a while, like 10 to 15 years for it to get critical mass. I think some form of reference-based pricing, not the blunt instrument version that's out there now, but more elegant forms of it, like the bundling work that Tom and Jay are doing and others, is going to be, in the next 4 years, as prevalent as CDHP is today. I think it'll get there in half the time it took CDHP because of all the price pressures and factors we've talked about previously. And it'll be on two levels. Employers who are buying care are going to have to either choose between that or getting out of healthcare altogether. And employees that are using their own money are going to almost self-impose a reference price. Why would you pay more? So lastly, ending and beginning with the end in mind, recall what the opportunity is and how misspent the dollars are today, right? Think about the partners you can connect with to help make that shift, to flip it to what any rational market would allow and support. Instead of 80-20 going to the highest cost locations, flip it around. 80-20 of that $1 trillion spend going to the highest value locations. That's not just good for the providers. That's good for everyone who pays taxes. That's good for everyone who cares about where dollars go in our communities. And that's our charge at the Blue Book. I would hope that's your charge. And truly, personally and professionally, don't rest until we get there. Thank you.
Any questions?
Ryan.
If you go to the mic when you ask yours, please.
How do we determine the fair price? So when we look at those cost curves that showed the spread from $1,000 for a colonoscopy to $3,500, we draw those cost curves market by market and procedure by procedure. And then we look for a break point where there's plenty of providers offering good value, but it's never just a simple formula. It's never just the average, and it's never just the low. So in a market more rural, like somewhere in the middle of New Mexico where we do work, that fair price may be a lot closer to the 40th percentile because there aren't as many provider options out there. Whereas in a metro area, you might be way down towards the 20th percentile because there's so many different high-value independent provider options. So it typically falls between the 20th and maybe the 45th percentile, but it's something you have to do slice by slice, zip code by zip code, procedure by procedure. Any other questions?
It's a neat tool. I'm very impressed. How do you get paid? Is this available to, you mentioned TPAs, but can a cash pay consumer or a physician out in the middle of nowhere utilize your tool?
Sure. So how do we get paid and who can use the tool? So our typical model is the self-insured employer, through either directly or through one of our TPA partners, purchases the tool. HealthSmart has taken a leadership position and is actually rolling it into their solution for their employers. Normally, our price is $1.75 per employee per month. We have a free version of the tool for consumers, but it doesn't have the detail that I showed you here. It just has general pricing information. And then our view is that if you're a high-value green provider, and I don't think you'd be sitting in this room if you weren't, we're happy to list you as such, and if you want to do direct scheduling, include that functionality, and it's nominal. And at that point, you then are on the tool and can see the tool as well. So we're happy to work with the providers in that way as well. Okay.
I like this Sisyphus comparison. So I think we're already there. Your question was, when do we reach the point, the tipping point, that you go from being Sisyphusian to going with gravity? So last time I bought health insurance for my employees was this year. $6,300 for deductible, $12,600 for a family, $1,300 a month, $28,200 out-of-pocket costs before you start to have $1 paid by insurance. So to me, we're there. And I'm angrily there as an employer and as a physician. So what is it going to take before the consumer and the employers finally push this over to really focus on cost? I mean, we'd be better off to have a major medical plan that costs us nothing.
Yep.
And HSAs to pay out of pocket with tax deductible dollars to pay for this stuff. So I think for people in this group are very well informed, and we already know this. I mean, this is a fait accompli for me. I mean, I've known this for 2 or 3 years. So what is it going to take for finally to where the critical mass of people finally know this and push it forward, so where we are cost conscious instead of having some third party, primarily the government, pay for things and run cost out of control?
Yeah, so that's the crystal ball question. My take on it is that even though we're all highly aware of high deductibles in this room, if you look at the data, it's still less than a third of folks. About 26% of folks have a qualified high deductible plan that are employer sponsored. So we're still, if you're sitting at a poker table with 5 of your buddies, one of them may actually care about cost. That's not enough. We got to get to where 3 of them care about cost. So depending on what happens on the exchanges and what the migration is from employers or individuals onto the exchanges, almost everyone on the exchange is going to care about cost right out of the gate because of the plan design. So I don't know if it's 1 year or 5 years. I think it's in that time frame when you get to 3 of the 5 folks at the poker table care about cost. That's my hunch, but there are folks who spend more time thinking about that than I do, I'm sure, as well. That's my hunch, though. Yeah. Anything else?
Great presentation. You did mention earlier about the high deductible health plan, driving consumerism. I'd like you to respond to something that we see out there, and that is when somebody does have a qualified high deductible health plan utilizing an HSA, it kind of starts, the behavior starts to look like what Adam spoke about this morning.
Yeah.
As long as the cost is within their deductible, their piece of the nickel, then they're cost conscious.
Yeah.
But if the procedure is over their high deductible, all of a sudden all that consumerism that we've built goes out the window. And so that's why we're not huge fans of HSAs, because of the linkage to qualified high deductible health.
No, I think you're spot on. So you got 2 levers, right? You've got out of pocket, and then in our world, you've got what we call in your pocket. and you got to have one of them active. So when you think about some of the things that Adam talked about of saving or sharing 20% of the savings back with an employee, if an employee is through their out-of-pocket, it's the rare individual who's going to care sort of altruistically about getting a fair price for their employer. So always have the in-your-pocket piece there. So some of the surgery arrangements that the Kempton and HealthSmart are doing are fantastic to say, you go here, you don't pay anything. But if it's disruptive, if it's a hassle, if I have to travel, I'm not going to pay anything anyway because I'm already through my out-of-pocket if I just go to the hospital across the street. So I do think we have to be more aggressive on the incentive side because the savings are so tremendous, right? $1,000 check back to an employee, even if you have to gross it up to tax it, if the employer is saving 30 grand, worth it all day long. Now, where we run into sticking points is on HSAs and other things. There are lots of mechanisms that prevent employers from paying employees to do the right thing, right? Like you can't put $1 into that HSA until they've paid through their deductible. So, or their out-of-pocket rather. So there are lots of issues, legal issues, that make it difficult to do the simple, obvious right thing and share some of those savings with employees. We're spending more time with Adam and his group to understand some of those options because we know there's a needle through it, but there's a lot of forces to try to prevent it.
I was just going to say, in our state, we have a bill that's being considered by the legislature. One piece of it is a transparency piece, which, as people have said, if people have no skin in the game, they don't care what the price is. The second piece is going to get people's attention because this is not going to apply only to self-funded plans. It's going to apply to everyone. They're going to use reference-based pricing so that even if you have one of the BUCA plans, if you as a consumer find the price lower, like I'm really dying to have one of my patients come out to Oklahoma City to have surgery at Dr. Smith's center. Basically what will happen is if you save money off the reference, lower than the reference-based price, then not only does the consumer, basically what is going to happen is the insurance company and the consumer will split the savings.
Which state is this?
This is Maine.
Wow, I hadn't heard about that.
So it's not law yet, but I think once this happens, Katie barred the door. Hopefully, we'll have tremendous price deflation in our state.
No, I hope it passes legislation. That's fantastic.
Well, we expect the hospitals will fight it. The insurance companies probably don't want it, even though in theory they're getting good savings. Obviously, they don't want transparency, but no, I know they're not. But I think it would be a really hard PR for them to fight it, though. And I think the hospitals will have a hard time fighting it as well because of the PR, not because they want it.
That'd be a great precedent.
Absolutely.
Be a great precedent. Yeah. Thank you.
As a care provider who wants to be using a free market model and offering cash, or accepting cash payments, can you explain how we get on your radar? And you kind of covered it a little bit, but can you just kind of expound on that a little bit? You want to start off, you haven't done it before, you're scared about starting out, and are you going to have the patience, are you going to have the revenue? You want to make as many people know as possible that you're there to provide these services. There's no one else doing fee-for-service in your area. We talked about Price MDs, and it seems like there are a lot of companies doing kind of the same thing. How do we get on your radar?
Sure, you bet. So unlike Price MD and Atlas and others that are helping providers market and generate out, what we're doing is for providers that already have good value. So even if you're you're in the network of all the different carriers, if you're an independent provider, chances are you're green in our system already based upon the allowed amounts for your services. So you can literally shoot me an email. We'll look up your centers and see where they fall. And if you're already green, then we can talk about if you want to do direct scheduling, and we can add direct scheduling to the site so that people can hit you. So we're about, first and foremost, the folks that are already doing good work in the shadows, highlight them. And we're happy to do that. That's part of how we all, I think, win together eventually.
Thanks.
Yeah, you bet.
All right. Thank you, Julian. Thank you, Michael.